As I mentioned, I'm Kristen Quinlan. I'm a researcher with the Education Development Center, and I'll be facilitating today's webinar. I want to welcome you to our webinar. It's sponsored by the Transform Center. Transform stands for Translational Research that Adapts New Science for Maltreatment Prevention, and that's exactly what we're looking to do. We're looking to translate research into real-world ideas that you can implement in your communities to prevent child abuse and neglect. Today, we're going to hear from a single researcher. We're going to hear from Dr. Darcy Mahoney, who's going to be talking about how we can maximize the brain's ability to adapt in order to really effectively address issues of childhood abuse and neglect. We're going to have an opportunity for audience questions at the end of the webinar and also midway through the webinar. And we'll have some polling opportunities along the way as well, so we can learn more about you and your work and tailor our conversation accordingly. Now, challenging social problems can be difficult to discuss and difficult to hear. So if for whatever reason you feel you need to talk after this webinar or during this webinar, feel free to reach out to a trusted family member, friend, or colleague, or dial 1-800-662-HELP. 4357. Employer human resources and employee assistance programs can also provide resources for local referrals. We're very glad to have you with us today and every day discussing these challenging topics in order to change paradigms. All right, so before we get started, we're going to start with a couple of polls. First poll is, what are you hoping to learn from today's webinar? We're going to have you choose all that apply. The first option is, I'd like to dive deeply into the science on the neuroplasticity of the brain. The second choice is, I'd like to receive a broad overview of the latest science in early brain development, particularly for infants and toddlers who experience adversity. The third one is, I'd like to focus on how the science of brain development can inform real-world practice. All right, so a lot of folks are really interested in that implications piece. So they kind of, folks it seems want a pretty broad overview of the latest science in this area, but really focus on the implications of the science of brain development and how it can inform real world practice. So it seems like we've got a lot of practitioners in the room today. Our next poll is related to the pandemic. So, over the past 20 months or so, things have been quite stressful. We want to know how you've dealt with increasing levels of stress over the past year. Exercise or meditation, reading, eating, watching TV, movies, social media, connecting with friends, neighbors, loved ones, seeking data and information, sleeping, working, or something else. Okay, a lot of people were doing a lot of exercise, meditation, and we've got a lot of Netflix folks out there as well, so you are my people. Thanks for participating in our poll today. All right, so I want to start by introducing our speaker. Darcy Mahoney is a neonatal nurse practitioner and researcher who has advanced nursing research, education, and practice with a focus on neonatology, infant health, and developmental pediatrics. Her innovative work has led to the creation of programs that improve infant health and developmental outcomes for infants. As the director of infant research at George Washington University's Autism and Neurodevelopmental Institute, she also advances the body of research in infant health and developmental outcomes in high-risk infants with a focus on understanding the early brain and developmental trajectories in this population. Her research leverages her knowledge in neonatal nursing, behavioral and cognitive assessment, and training in neuroimaging to form an understanding of multimodal social learning and social perception among high-risk infants and toddlers. NIH, Office of Minority Health, HRSA, Robert Wood Johnson Foundation, United Way, and Macy Foundation have funded her work, and she's published in high-quality, peer-reviewed, interprofessional journals. As a fellow of the American Academy of Nurses and a Robert Wood Johnson Foundation Nurse Faculty Scholar alumna, we're lucky to have her participation for this important webinar today. Ashley?
I'm so excited to be here, and I wanted to start off by really having a robust discussion of kind of what we're going to talk about today and where we're going to go. So we're going to talk about understanding neuroplasticity in the brain, thinking about in the context of child abuse and neglect, but also in the context of how we can be helpful for these kiddos after these child abuse and neglect take place, what kind of prevention we can think about in helping this not to happen in the first place. So we're going to kind of take that in order, I'd say, for the agenda today. So pediatric stress and adversity have a vital link with early development, early brain and child development. This connection can lead to adverse childhood outcomes across the lifespan and can negatively affect physical health, social emotional development, and educational achievement. We're going to frame our discussion today around evidence-based recommendations from the American Academy of Pediatrics, the American Public Health Association, and the National Association of Pediatric Nurses and Nurse Practitioners. Because pediatricians, pediatric nurses, and nurse practitioners, like myself, work to prevent childhood diseases, we also need community partners. We need psychologists and psychiatrists. We also need counselors and school nurses and the many sort of different community members that you all represent in thinking about how we can manage child abuse and neglect, especially during this current sort of really big mental health challenges we see in kids right now. An introduction here, we'll talk about some innovative models of care towards the end where we can merge science of early childhood development and consumer behavior to really think about what the modern day patient and family might need. We know that health professional training has traditionally not integrated the expanding neurodevelopmental science of early brain development and poverty in formal education. So when we do these kinds of sort of webinars and workshops, I like to really bring forward some educational innovations in pediatric health that we're thinking about as we think about expanding neurodevelopmental science, but also really trying to understand how it relates to all children across sort of the various places where children are, from communities to schools to homes. So physical abuse of school-age children has tripled during the early months of the pandemic when widespread stay-at-home orders were in effect. Exactly what triggered the surge is not fully understood. As you guys talked about in the poll, you all did some stress mitigation, but we think that that probably has a lot to do with this. Some studies have reported upticks in child abuse and neglect, but it varies across the different cities and the different states in the country. What we know is that COVID-19 and pandemic-related stressors were sort of a perfect storm for abuse in children. Stressful situations can trigger poor judgment and impulsive reactions, and there was and is a great deal of economic stress, job insecurity, loss of housing during this potential time frame, sort of coupled with the closing of schools that can be a real reprieve for parents and kids. So there's been a number of studies that have really looked at kiddos. Most recently, one of the ones I have up there is one of 39,000 children treated in 9 different pediatric centers from March to September of 2020. And what they saw of the 2,000 plus kids that were victims of child abuse, most of them were older than the age of 5. So interestingly, I think despite the rise in sort of abuse among school-age children, it can be pointed out that there was actually no increase, at least in this study, in abuse of younger children during this time frame. If I had you all in front of me, I might ask you sort of why you might think that is the case. I think there are probably a number of different potential options to think about, but one of them certainly was that daycares and early childcare centers for little kids were considered essential in a lot of places and remained open, quite frankly. Even in the peak and the height of the pandemic in New York City, we saw those YMCAs. There was, large studies on the YMCAs that stayed open in New York City. So I think it allowed some families to function differently than the children that were at home without school or without being in school physically. So overwhelmingly, childhood experiences do not have to be thought of as what we think of as typical traumas. So there are certainly some of the more typical abuse and traumas that we'll talk about, but it does cover actually a much more wide range of experiences. So we can think of dogs frightening us, friends rejecting us, sort of tense or distracted parents, right? We can think of those as stressors. But there's certainly more severe abuse and neglect. So when we think of painful or frightening examples or experiences that happen that overwhelm a person, particularly a child, and particularly children that do not have that sort of warm, attentive listener, that warm person that can really give a sort of buffering effect to some of these adverse experiences, those are the times that we really see high levels of stress that we're going to keep talking. And those are the ones that sort of overwhelm the system that aren't ordinary. When we think of painful or frightening incidents that happen to a child, they can become a little bit more understandable if there's a supportive person that's listened to the child, that's emotionally upset all the way through, and the child sort of feels whole again, feels listened to. However, the impact of a child sort of depends on what the child is experiencing, their age, their previous experience, and most importantly, the supportive adults that the child has around them. So when we think of adverse childhood experiences, there's sort of a number of ways in which to think about it. And I think the evolution and the science of ACEs has really been remarkable over the last 5 years. So briefly, adverse childhood experiences are ones that harm a child and can lead to changing way how a child responds to stress. It could potentially damage their immune system, change their genetics, what we call epigenetics, and it can profoundly impact their health over time. We have seen in studies that ACEs or adverse childhood experiences can cause a burden of chronic illness and mental illness as well. Where the science comes from was a CDC study, a CDC Kaiser study on adverse childhood experiences published in 1998, so quite a bit of time ago. And the measures that they had for adverse childhood experiences, some of which are listed here, included physical, sexual, and verbal abuse, physical and emotional neglect, a family member who may be depressed with mental illness, addicted to alcohol or another substance, or in prison, witnessing a mother or another parent being abused, losing a parent to separation, divorce, or another reason. There have been subsequent ACE studies and other ACE surveys to explain ACEs to also include things like racism, gender discrimination, witnessing a sibling being abused, witnessing violence outside the home, witnessing a father being abused by a mother, being bullied by a peer or an adult, involvement in the foster care system, living in a war zone, living in unsafe neighborhoods, losing a family to deportation. And so I think this more expanded thought, really science around ACEs instead of the sort of 10 ones that were defined in the 1988 study, I think is probably more helpful to families right now. And so I like this 3 realms of ACEs as we think of childhood experiences, community experiences, and climate experiences. And especially when we think about COVID, I think we can really think about where a child may have a multitude of different ACEs depending on the situation that they sort of have lived in over the last 20 months. So developing brain science can show us that in the absence of protective factors, toxic stress in children's developing brains can be detrimental. Stress is the body's normal response to challenging events or environments. And we know that positive stress, things like the first day of school, a big exam, a sports challenge, is part of growing up. And parents and caregivers can help children prepare for and learn how to handle those positive stressors, which in moderation doesn't last long, right? The stress goes up and then comes back down. It can increase your heart rate, increase your stress hormone, and then sort of return to normal levels quickly. So the effect of trauma in the developing brain is where we're going to sort of lead our discussion now. And children can, again, experience symptoms and difficulties associated with complex trauma. So when we think of complex trauma, there's some of the other ones that we talked about earlier. And there may be some related to early life adversities, such as exposure to alcohol in the antenatal period, placement instability, poverty, neglect, and persistent or pervasive developmental issues. Then practice and policy, I want to just make sure that we are going to talk about trauma-informed interventions towards the end, but they can really help us think about how to improve cognitive functioning. But there isn't as much research as I wish there was on trauma and cognitive development. So we'll talk about what there is, but frankly, there's not as much as I wish there was. And then the interventions that we have that can target trauma are necessary, but may not be sufficient to meet the developing needs of children, especially in the current system that we have where mental health and physical health are often separate from each other. I wanted to sort of talk here about how development happens. So during fetal development, so we're going to get a little in the weeds for the next 3 slides, so sort of stay with me on the biology, but I'm going to try to bring it back to what I hope you all think is really relevant. And I think this will help build that pyramid for us in trying to understand everything. So during fetal development, neurons are created and they migrate to form various parts of the brain. As neurons migrate, they differentiate or specialize, right? That's the idea of differentiation is just specializing to govern specific functions in the body in response to chemical signals. The process of development occurs sequentially, or as you can think of from the bottom up. That is, from areas of the brain controlling the most primitive functions, so things like heart rate and breathing, to the most sophisticated ones, like complex thought. So the first areas of the brain to fully develop are the brainstem and the midbrain. At birth, these lower portions of the nervous system are very well developed, whereas the higher regions, the limbic system and the cerebral cortex, are rather primitive. So higher function brain regions involved in regulating emotions and language and abstract thought are the ones that grow rapidly in the first 3 years. So when humans become frightened, a complex cascade of events can occur in the brain and body. The fear responses begins in the amygdala, which you can see there towards the bottom. It's a small almond-shaped section of the nervous tissue that's located deep within the brain, and the amygdala is responsible for emotions and remembering danger so that we can avoid it in the future. This tiny structure is part of our brain that helps us to recognize danger, and when it does, it produces cortisol. The amygdala alerts the body to danger and it readies it for flight or freeze responses. The hippocampus, which you can see here sort of right down by the amygdala, is a small seahorse-shaped structure that's located deep in the brain also, and it plays a vital role in memory formation and storage. The reason for mentioning these and thinking about how ACEs are involved with them is that ACEs can potentially change these two structures as they're directly related to complex post-traumatic stress disorder. A smaller amygdala, so if your amygdala is smaller as it relates to potentially having experienced these ACEs, if it's smaller, it may inhibit our ability to recognize what we're hearing, seeing, or smelling. For instance, we might hear firecrackers and see a flashback to a time we witnessed gun violence, right? So it can have a significant link with post-traumatic stress disorder in that way. And traumatic experiences do not just harm a child emotionally, they also harm their brain, and experiencing child abuse early in life can dramatically change the number of neurons in the brain and can decrease our ability of the neuron to communicate with one another. These changes are thought to be caused by constant exposure to the stress hormone cortisol, which we just spoke about. Cortisol, when sent from the amygdala, recognizes the threat. It readies our body for that fight or flight. But when a child is subjected to these different experiences over and over, cortisol is continually pumped into the bodies of children, and a child's brain chemistry may never return to baseline. In that case, cortisol can act sort of poisonous to the developing brains, causing damage to these sort of vital brain structures as they're being formed or sort of as they're maturing. That can be tough to alter. So when we think about brain development or learning, it's actually a process of creating, strengthening, and discarding connections among neurons. These connections are called synapses, and synapses organize the brain by forming pathways that connect the parts of the brain governing everything we do, from breathing and sleeping to thinking and feeling. This is the essence of postnatal brain development, because at birth, as you see here, very few synapses have been formed. The synapses present at birth are primarily those that govern our bodily functions, such as heart rate, breathing, eating, and sleeping. For those of you who are new parents, this may ring a bell for you. The development of synapses occurs at an astounding rate, though, as you can sort of see in this picture, from early childhood years and in response to what a child experiences in their everyday life. At its peak, the cerebral cortex of a healthy toddler may create 2 million synapses per second. By the time children are 2 years old, their brains have approximately 100 trillion synapses, many more than we will ever need. And based on what happens in early childhood, based on these experiences, some synapses are strengthened and remain intact, but many of them are gradually discarded. And this process of synapse elimination, or you may have heard it called pruning, is a normal part of development. By the time a child reaches adolescence, about half of their synapses have been discarded, leaving the number that they will need for the rest of their lives. Adverse childhood experiences may dramatically change the connections between the number of neurons in the developing brain. These neuronal changes can change our personalities and our perceptions because pruning rids the brain of synapses that are not needed. And the prolonged activation of stress hormones in early childhood can reduce neural connections in the thinking area of the brain, the one that's dedicated to learning and reasoning, thus potentially limiting cognitive ability. Continuous trauma can weaken the remaining neural pathways to thinking about part of your brain, to the thinking part of your brain, and strengthen the neural pathways to the survival part. So sort of bypassing that thinking part, some people can be less capable of coping with those adversities as they grow up. one of the things that I wanted to make sure I said that we should know is that the brain is not static after early infancy and into early adulthood, but it's sort of this vibrant and changing organism that can change with new experiences. And so we're going to touch on that as we think about neuroplasticity soon. So I don't want this all to sound like gloom and doom. There's a lot that can happen, but this is sort of the early brain development piece. So when we think about stress, stress is a really sort of important part of life, right? There's positive stress that's moderate, it's brief, it's generally a normal part of life. Some of the ones that I had mentioned earlier. Learning to adjust to this type of stress is essential for healthy development. And then there's tolerable stress. It includes events that have the potential to alter the brain negatively, but occur infrequently and that give the brain time to recover. So for example, a death of a loved one. And then there's toxic stress. Some of this has been sort of written about widely over the last few months, but it includes strong, frequent, prolonged activation of the body's stress system. So thinking about chronic neglect. And when we think about that as high levels of toxic stress, we can think about those hormonal changes that we said, the changes of cortisol and adrenaline, those stress hormones that help you react to perceived threat or danger. But also when we have those high levels of hormones, we know that it can keep our blood pressure high. It can weaken our heart and circulatory system. It can keep our glucose levels elevated and disrupt our immune system. It can, in early life, like we said, it can really dramatically change the architecture and function of the brain. We also know that trauma can be linked to thymus involution or atrophy of the spleen. So thinking about how it might impact our immune system. Impaired immunity and inflammation can increase our risk of cardiovascular disease and diabetes, viral infections. So stress, in toxic stress especially, when we keep those really high levels of hormones and inflammation in our system, can lead to a lot of challenging diseases over time. So I wanted to just show you guys that there's a lot of stress measurements that we've been thinking about a lot in pediatrics. Some of these have, in fact, really been woven into our pediatric visits. They've been woven into our schools and our school nurse screening. So some of them here, some places do an adverse childhood experiences scale. Some places do a sleep scale as sort of the first, like how are you sleeping, as sort of a metric for thinking and talking further. A perceived stress scale, those are some that we often offer to new parents. But a lot of these, quite frankly, are ones that are only used in research. And I think that there's probably some real thought to how can we begin to use some of these, both qualitative and quantitative metrics, to better identify kids that need a little bit more intervention services that may experience high levels of stress. So when we think about the sort of quantitative side of things, I want to make sure we talk about how the sort of nervous system is set up. We have the autonomic nervous system, which is part of the nervous system that's responsible for the control of bodily functions that are, for the most part, not consciously directed. And there's another part. We have the sympathetic nervous system, which is most commonly summarized as the fight or flight, something we've talked about, and the parasympathetic one, which is our body's ability to sort of rest and digest. And when we think about these ones, these are sort of the ways in which we can begin to think of how we could measure a child's high rates of stress. What I'm going to show you in the next slide are some physiologic measures that I think we can begin to think about in our pediatric visits, for example. So we can measure with an electrocardiogram the sort of heart rate. We can measure the complex respiratory effort that kiddos have. We can measure the pre-ejection period, which helps to understand the sort of regulation and the time interval between the ventricular polarization, which is sort of the time in your heart that something fires, and the ejection. So I think there's a lot of ways that we can begin to measure various parts of what childhood stress looks like, but it's not something that we do routinely. We've seen from some new research that cardiac measurements of autonomic nervous system are highly responsive and sensitive to changes that occur in an individual environment. They've been well studied and their relations to child and mental health have been established, but we don't often measure reactivity, higher or lower reactivity in our sort of pediatric visits in any sort of way. But if we start to do that, we can begin to understand how stability may impact the various plasticity that we're going to talk about in just a few slides. So implications. The measurements of stress can be messy, complicated, and must be treated with caution, right? So some of these qualitative measures give us a screening tool for stress, but doesn't exactly tell us what's happening in kiddo's brain. And the stuff that's happening in kiddo's brain, unless we do quite a bit of invasive research, some of these more proximal measures like heart rate and respiratory rate, ejection fraction, are tricky because they haven't been used quite a bit. Profiles are an exciting new way of understanding one's biology and predisposition. So can we create sort of a larger picture of thinking about both this qualitative and quantitative measurements that we have? But we need quite a bit more work in these intervention studies and profiles to think about how to use them. But what we currently have is we sort of operate in this rigid, antiquated, generic, single channel pediatric primary care system where we screen people. And in the best of circumstances, if they do screen positive, we can get them to a social worker, psychologist, school nurses and counselors in a really robust way. But that is often not the case, as I know many of you know, is kids are often sort of left and it's a system that can be really broken at times. So I think we're gonna pause here. We did a lot of the biology part early and take some questions. I'll let Kristen navigate this.
Absolutely. Thank you so much, Ashley. Appreciate it. So we have a couple of different questions that have come in. One of the questions that is interesting to me, it seems as if stress has the potential to be really multi-generational. So stressed youth become stressed parents dealing with their own trauma histories and the impact of stress on their own body systems. So I'm very interested. Can you talk a little bit about multi-generational stress and issues of maybe historical trauma?
Sure. So we're going to talk a little bit about managing parent stress. But yes, I mean, the answer to the question is there's absolutely strong science to suggest that multi-generational trauma, families sort of continue to deal with over a long period of time can absolutely impact the way in which a parent parents and the way in which then a child develops. And it can be cyclical. I mean, a lot of the work that I know you all are quite robust in is really trying to understand trauma and generational trauma of abuse and neglect. We know that if a child has been abused, their abuser was often abused, right? And so we'll talk a little bit about managing stress a bit, but I'm not sure I'm going to have a full answer in this particular case, but I'm going to try and give you some ways in which I hope that we can begin to mitigate this sort of cycle and intervene in places for both parents and children that can stop that two-generational cycle.
Excellent. Thank you so much. Another question that came in is regarding the future of research in this area. So I guess the question that the attendee wrote in is if you could conduct any further research on this issue, how would you want to proceed? So I guess the question is, where's it going? Where's this research? What are the next generations going to be looking at?
I think if I could conduct any research, one of the things that I'd really want to do is begin to collect more data outside of just screening data. I think that's where we're really, really limited right now. I think as a population of pediatric clinicians, I know in schools, right, school nurses will collect a lot of sort of qualitative data and screening data, and similarly in pediatric offices, but we don't collect a lot of data that's actually really easily captured, right? I mean, think about what you all may have on your Apple Watch or your whatever you like to use, your Fitbit. You collect a ton of data. You collect data on your heart rate and your respiratory rate, and you collect, data when you're running and when you're not running. I mean, imagine if we had the ability to capture some of that data in children on an ongoing basis, what we could begin to glean because for some children, what we might perceive as really, really stressful events, they might be able to have a buffer from those events, which we're going to talk about in a few minutes, from a parent or a caregiver, a grandmother, an auntie, somebody at school that really is able to bring those physiologic measures down in ways that we don't even understand right now. For me, if I had a pie in the sky, I would love to take a population approach to really gaining as much data in the physiologic sense that we can and coupling it with the qualitative data that we already gain.
Thank you, Ashley. I appreciate that. And the other question that we saw come up is, how does abuse and neglect impact early learning?
Sure. So some of what I mentioned in terms, so learning is directly impacted from your brain's ability to really focus, right? And so some of the things that I just told you, when you have these high levels of cortisol, these fight or flight responses, it's almost impossible to bring your brain down to baseline to be able to focus on learning. And so what we know is that things like executive function, memory, task switching, that sort of higher order of magnitude thinking directly relates, and importantly, sort of relates to a child's ability to focus. And when that doesn't happen, it can really impair learning. So I think the learning, as we've seen over the last 20 months, learning environments are really important. So both where a child learns, whether at home or at school, is important for where a child feels safe. Do they feel safe in their learning environments? I think there's been quite a bit written about by a number of scholars, especially my colleagues in the BIPOC community, that have written about children learning from home that has felt safer, that they have felt more able to learn, because the school environments, they felt these higher levels of racism and discrimination there. And so I'm certainly not the scholar in that realm, but I have seen quite a bit of research to suggest that those environments caused high levels of stress for those children, and they didn't learn as well as they did at home. So I think that there's really quite a bit to really think about as we think about the environments in which a child learns. An environment in which a child feels safe and secure will be important to how they learn, on the day-to-day.
Great, thank you. And we're going to pause questions for now. I saw a couple others come in, but we'll have an opportunity for some additional questions after the second part of your discussion. So we'll move on to that now.
So COVID has changed a lot of things, and I want to make sure that we sort of take some time here to think about all that we've talked about in the last few slides, or in the last 25 minutes, and think about COVID as well. So the CDC currently reports that the risk to COVID is low for young Americans. We've seen that play out. We're not going to have any sort of debates on how low or high that risk is. But what I want to talk about is that research on natural disasters make it clear that compared to adults, children are more vulnerable to the emotional impact of traumatic events that disrupt their daily lives. And I think many of us can see that. The closures of schools, the closure of sports were very, very impactful for children and children's mental health around the world. The American Academy of Pediatrics has recently just called a state of emergency for mental health in children right now. And it is clear that the disruption of COVID-19 in their lives has been extraordinary, perhaps a once in a lifetime sort of event at such a grand scale. Much of the research we have on this comes from things like earthquakes or natural disasters like Hurricane Katrina, which are sort of geographically bound. And we have some data on that, but at such scale, this has been quite different. And so I wanted to make sure that I touched on some of the things that are causing high levels of stress in parents. So parents aren't just worrying about money. They are worrying about changing their behavior to compensate for lack of income, the fears of future financial instability, and food availability, including formula. Over a third of parents in this survey, which comes from California, say that they've skipped or reduced the size of their own meals as a result to the COVID-19 crisis, and that the number increases significantly among parents with a child that's 1 to 6 months. And parents who have been enrolled in early intervention services also, and Head Start, as you can see here, also have really significant increases in those numbers. Overall, 12% of parents have skipped or reduced the size of the meals they provide for their children, which disproportionately affects single parents, parents with children enrolled in early intervention or Head Start, and in this particular capacity, children that live in a city and non-English speakers. One clear manifestation of financial instability is parents' ability to feed themselves and their families in this pandemic. And in less than sort of a year, right, this has translated to greater food insecurity of proportions we've never seen before. We have seen some good legislation that has come out to really help families. We've seen the CARES Act and the American Rescue Plan that have really been targeted at these sort of challenges that we've seen. But ensuring that children have safe, secure environments in which they grow and learn and have this strong foundation is what's going to help them thrive. And food insecurity is a big part of that. And in this case, when adult responses are sort of unreliable and parents don't know what to do, it can really affect how children sort of solve problems and how they learn. The good news is that the brain is plastic, and it wants to heal. The brain is continually changing in response to the environment. If toxic stress stops and is replaced by practices that build resilience, the brain can slowly undo many of the stress-induced changes. There is well-documented research on how individual brains and bodies become healthier through things like mindfulness practices, exercise, good nutrition, adequate sleep, and healthy social interactions. In the past few years, researchers have started to examine the impacts of positive childhood experiences, or PCEs, on children and adults. There is something called the PACEs connection, sort of thinking of these sort of positive experiences that are particularly interested in the interplay between positive and adverse childhood experiences. And there's some, I think, important research as we think about these roller coasters that children have been on. So again, amidst the COVID-19 outbreak, everyday life has changed. And for some people, will continue to change for quite some time. Often it changed with little notice, and it still is changing for kids with little notice, especially kids who have to quarantine or get out of school for various reasons. Children may struggle with the significant adjustments to their routines. They thrive in routines, and when school closures, social distancing, home confinement interfere with their sense of structure, their predictability, their security, it can be challenging for them. Young kids, even toddlers, are keen observers of people and their environments. And they notice and react to stress in their parents and other caregivers, their peers, and their community members. They may ask very direct questions about what's happening, and they may have really strong feelings about what's happening. They may have fear or worry, sadness or anger about pandemic and related conditions. And children worry about their own safety. They worry about the safety of their loved ones, and they worry about how they'll get their basic needs met, things like food and shelter and clothing. They feel this, and they feel these uncertainties. And so while children eventually return to their sort of typical functioning when they receive this consistent report from sensitive and responsive caregivers, others may be at risk for developing significant mental health challenges, including trauma-related stress, anxiety, and depression. And children with prior trauma or pre-existing mental or physical problems, and those whose parents struggle with mental health disorders, with substance misuse or economic instability, are especially high risk for these economic or these emotional disturbances. Excuse me. How can we help kids cope? And so I focused this here on during the coronavirus pandemic, but I think everything I'm going to say can really be translated into any really big stressful event that a child goes through. But I think, as I sort of said, with the high rates of abuse and neglect that happened during COVID-19 and the sort of coronavirus pandemic in general, I think a lot of this that I hope can really cross boundaries. So how to help your child work through fears and uncertainties. So make developmentally informed decisions about what a child needs to know in order to feel safe. Focus on creating environments where children can ask questions that matter to them. Reassure children that they're going to be safe and that you as a caregiver will take steps to ensure that they will be safe. I think a lot of parents have done that with respect to explaining vaccines or masks to kids, that these are things that can help keep children safe during this time of uncertainty. Encourage compassion for vulnerable people and expanding your child's circle of concern. Avoid stigma by emphasizing that getting sick may be part of being a human being, and we all need to help each other stay safe. According to SAMHSA, so part of the U.S. Health and Human Services, a trauma-informed approach refers to how an organization or community thinks about and responds to children and adults who may experience or be at risk for experiencing trauma. In this approach, the whole community understands that the prevalence and impact of adverse childhood experiences, the role that trauma plays in people's lives, and the complex and varied paths are different. And they may be important to understand that there is variation to paths for healing and recovery. For example, a trauma-informed approach asks, what happened to you, instead of what's wrong with you. It is designed to avoid re-traumatizing already traumatized people with a focus on safety first, including emotional safety, and a commitment to doing no harm. A trauma-informed approach is most successful when an organization or a community builds policies and practices based on this foundation. I know our Children's Hospital here in DC has a really strong focus on trauma-informed care. But some principles to really think about for trauma-informed care and neuroplasticity are providing safe environments, supporting children and caregivers to understand the links between traumatic experiences and cognitive difficulties. Developing these and supporting positive relationships in children's lives and these sort of buffering experiences for kids is really, really profound. Offering all children in care targeted trauma-specific interventions, some of which we'll talk about in just a minute, and maintaining these interventions in childhood and adolescence. So some of those can be really important. So what sort of behaviors should parents watch out for? So this is a question that I get quite a bit from families. And so I thought it was helpful to sort of think about. So emotional and behavioral changes in children are expected during times of trauma and stress, like in a pandemic, as everyone adjusts to a routine and daily norms. Some children may be irritable or clingy. Some may regress, demand attention, have difficulty with self-care, eating and sleeping. And new challenging behaviors are natural responses. And adults can help by showing empathy, patience, really modeling the behavior that we want to see in our kids. And with strong emotional support, kids often really come through this sort of back to this typical level of functioning. And so when we think about things to make sure or to sort of reassure kids, the 3 R's I think can be helpful in creating an environment that feels safe for kids. So reassurance, routines, and regulation. So reassure kids about their safety and the safety of their loved ones. Maintain predictable routines. Support kids in the regulation of skills by helping them manage difficult and emotional situations, and then sort of check in with them. And then again, like I said, ensuring there's a presence of somebody that can be responsive to their needs. Now, for a question I think that gets to the heart of some of the things that I was asked earlier, how can we support parents and how can parents sort of best support their children? So I think this can really be helpful for everyone, not just kids. So understand the reactions to the pandemic may vary. For those of you who haven't watched the news over the last 20 months, maybe this doesn't feel right to you, but for most of us, there are so many different reactions to the pandemic right now that I think it can be really, really challenging. And we have to be empathetic to the many different reactions we see. Ensure that there's somebody that can be there to respond to them. Social distancing does not mean social isolation. So making sure that kids can still feel like they're a part of something. And there's probably a lot of ways to do that. And as we've seen, being outside and being with friends is probably, you know, one of the more safer things kids can do to not feel so isolated. Providing them age-appropriate information, or if you're working with families, making sure that the information you provide for them is at the education level where they can best consume it. I mentioned creating a physical and emotionally safe environment by practicing reassurance, routines, and regulations. Keeping busy is good for kids, and overly busy, not so good for adults. So I use this one a little bit more cautiously. Increasing a children's self-efficacy, making sure that they know the tools that they have in their toolbox to be able to manage stress. So if breathing techniques, if yoga, if exercise, if running around, your kids all have these sort of tools in their toolbox to be able to manage emotions and stress. And I would sort of encourage you to let them know that they are there and they exist. Create opportunities for caregivers, which may mean yourself to take care of themselves too. And then professional help is important and needed at times. Emphasizing strengths like hope and positivity are really key. What I wanted to show you on this slide, this again comes from the Ed Trust in California, is that what parents wanted is they wanted access to their child's doctor or clinician via telehealth through technology during the pandemic. They wanted examples of resources to help parents support their child's emotional, social, and cognitive well-being. And they want to connect parents, they wanted to be connected to things like food and housing and employment. So I put those sort of 3 arrows there, and that parents are telling us what they feel like they need to be successful in helping their kids. When we think about what recovering from trauma looks like, especially in this sort of time, I want to sort of remember that we should ask people what they need, because sometimes they will absolutely tell us. So I'm going to tell you a little bit about what I think that we could do to help support brain development in traumatized children and youth, but also in families. And some of the things that I think we could do are using a little bit of more innovation that we have. So I've just put a couple of these up here, but things like group social care. So oath care is something that is really they call themselves onboarding for motherhood, but it's this essentially this group of people that can come together through social means, through an app, that can talk amongst each other and also talk with clinicians to capture health as it's happening sort of in this everyday life. It can be sort of episodic in nature, as I need help with sleep training. I need help with a baby that won't fall asleep. I need help with postpartum depression, but it lives in this sort of continuous care model of a group of people getting care at the same time. Cortica, for example, offers a whole child perspective on autism, offering specialty services and biomarker assessments. And so I say this in the context of like, we have used a lot of the same things for a very long time. We have used sort of these early intervention services and screening tools for a while, and we often haven't taken it the next step further to really think about how we can involve an entire community in the care of kids and how we can involve technology. So when we think about treatment for trauma-affected children and youth, I think there's promising evidence-based intervention models coming for helping to restore, for helping to restore social, emotional, and cognitive health in infants and children who experience this sort of stress. So we think about other ones like the attachment and behavioral catch-up. These are interventions that are designed for caregivers of infants and very young children up to age 2 who have suffered from neglect. ABC takes place in a caregiver's home and includes both the caregiver and the affected child over a 10-session treatment. There's other sort of levels of interventions that we see. We know that there's child-parent psychotherapy, which is sort of this flexible two-way model targeted at young children from infancy through 6 with attachment, behavioral, and mental health problems. And it can be used with birth parents, foster parents, kinship parents. And then parent-child interaction therapy. We know there's play therapy that's used, cognitive therapy, mindfulness meditation, and sort of the list of lots of other, as children get older, that I've listed here that I think can be particularly helpful for you all to think about. These are just some more resources that people for when to know to call for help. I think I'll end on this slide as I want to make sure people have what they need in order to make sure they connect if they do need help.
Great. Thank you so much, Ashley. That was really informative. We've seen a bunch of questions actually come in. So I want to start with one slide back. You were talking about, trauma-informed care and different types of therapies that kids can receive at various ages. And so one of our participants asked, do you think there's an ideal age in terms of brain functionality at which mental health interventions are really most effective?
I think early interventions are always better in almost sort of every capacity. So intervening early is generally true across almost every diagnosis or challenge that kiddos have. So no, I think the short answer is no, there's not an age at which I think you have to wait to get therapy. And I think some of these therapies can start really early, especially as it relates to sort of attachment and working with kids to sort of nurture a child and how routine interactions can optimize a child's development. So even as early as 6 months, really showing parents how to best have that quality interaction that sort of serve in return.
Great, thank you. And several of our participants are actually from the legal system. And so we had some questions with regard to the data that you've had and the research you've presented and how it might be used in the legal system to support children who are the victims of abuse.
These are things that that Kate is probably best suited to answer. When I think about the way in which I think these can be used in the legal system, I think it's probably most helpful to think about how we can define abuse and neglect and whether these types of sort of physiologic data can help us understand how abuse and neglect presents in kids, because it really does present, as you all know, on this sort of spectrum, with some kids being able to buffer these abuses in ways that may in fact hide them. But for other kids less so. And so the ones that are probably less so, you can see, right? So we're probably much more easily detecting kids that either have really bad trauma and can't, and sort of it overwhelms their system, or versus kids that have, trauma that may not reach whatever level of abuse that becomes visible in the various ways it can become visible.
Thanks, Ashley. And I want to note the chat for those of you who didn't see it. Kate did weigh in to say that we're going to be exploring this a little bit more on an upcoming podcast with Dr. Darcy Mahoney. So definitely mark your calendars for that. You'll see that coming out in the Transform marketing materials later on. Ashley, I think we have time for probably one more quick question. You talked a lot about physiological measures for kids with ACEs. The question came in, is there a way that we can kind of interpret some of the physiological data that we get from adults who had ACEs, kind of back to children? What's the value, I think, of that physiological data from adults, and how can it be used?
Yeah, so I think the physiologic data can be used to help people understand sort of whether they're operating in these sort of high stress environments, and what's their baseline. Is their baseline, really high levels of cortisol? Is their baseline really high levels of sort of this heart rate ejection fractions? And what their baseline is, what interventions can bring those numbers down? I think that as an adult or as a child would be really helpful, right? If you don't know that you're always operating at this really high level, because that's sort of always where you've operated, it can be hard to know what the feeling of of being at a different level might be. And so I think that might be one way of thinking about how that data could be helpful for adults. For kids, I think it could be particularly helpful in especially for screening kids, as opposed to the visits we have are really episodic with our pediatricians and our nurse practitioner. We see them once a year, as kids get older. So really having some more continuous data could be very helpful.
Great, thank you for that. And I don't know if you're seeing the chat, but later on you will. And lots of kudos in the Q&A pod.
Good, thanks. I'm sorry I didn't have quite as much time to answer questions, but you know where to find me. And we'll do a podcast, like Kate said.
Yes, so definitely mark your calendars for that. All right, so we just want to encourage you to visit www.thetransformcenter.org for details about our upcoming events and publications. If you have suggestions on what you'd like to see covered in those sessions, you can email us at the transform@urmc.rochester.edu. At the end of today's webinar, as I mentioned earlier, you're going to be kicked directly to our evaluation. We'll put that in the chat pod as well. The evaluation really helps us improve the quality and content of our services, so we really appreciate your feedback to that. And as I mentioned earlier, bonus, you can be eligible to receive a $20 gift card for filling out the survey. You'll be entered in to win that contest if you participate, so appreciate that. Please remember to follow us at the Transform Center. And I just want to take a second and really thank you so much, Ashley, for your time today. This was really, really informative, and you took a really complicated system like the brain and broke it down in a way that was really helpful and helped us understand all the implications of that as well. So really grateful for your time today.
Yes, thank you for having me.
All right, and so we look forward to seeing you during our next webinar.